Hello everyone. We are going to wait a minute maybe for people to join, and then we will start with the webinar. Okay, I guess we can start now. So hello everyone. Welcome to our webinar today. My name is Kamelia Markovska and I'm project manager for Work Package 6 Education and Training. I will be your host today. The topic today, as you can see, is clinical practice recommendations for the diagnosis and management of XLH. I want to say thank you to MTG2 for organizing this webinar. And without further ado, I will give the word to Corinna Grasemann to present the others from the panel.
Thank you, Camelia. Good evening, everyone, and welcome to MTG2's webinar on clinical practice recommendations for the diagnosis and management of XLH. I would like to welcome you all on behalf of my co-chairs, Marta Kirchhoff from MTG2 and Eva Kassi, and we have the great pleasure to introduce today Dieter Haffner. He probably doesn't need much introduction. He's so very well known in the field. Professor Haffner is a pediatric nephrologist from Germany. He is the director of the Center of Pediatric and Adolescent Medicine and head of the Department of Paediatric Kidney, Liver, Metabolic and Neurological Diseases. And he was the coordinating and lead author on the clinical practice recommendations that were published earlier this year. So today I'm very happy that you will be presenting these guidelines, breaking them down for us, and there will be pediatric and adult recommendations that we are now looking forward to. Thank you.
Thank you very much, Corinna, for this kind introduction and for the possibility for me to present this huge project, which was a teamwork of many people to present here today. So these are my disclosures, and here we go. So I prepared 3 slides as an introduction into the disease. Before then, we start with the guidelines. So first of all, XLH is rare. It's a multisystemic disease, and it's mainly affecting the bone as a metabolic bone disorder. And of course, it's affecting children and adults. Although it's rare, it's the most frequent hereditary cause of hypophosphatemic rickets, with a prevalence between 0.7 and 4.8 to 100,000, and an incidence of about 4 to 100,000 live births. And it follows an X-linked dominant inheritance. So that means that even a woman with one, it's called healthy X chromosome, also get affected. And as a rule of thumb, about 80% are familial cases, which are more easy to diagnose. However, at least 20% are sporadic, and they are sometimes challenging to diagnose. So it's pathogenic variants in the PEX gene causing a lack of the encoding enzyme. It's an endopeptidase. And if you want to get a Nobel Prize, then you should find out how it in the end works. We don't know. The osteocyte is still a black box. There are many genes who interact together and many proteins. But what we can say is that in the end, PEX malfunction results in inadequate secretion of the phosphaturic hormone fibroblast growth factor 23. So the bone talks to the kidney. And what is the message? The message is we don't need phosphate. And the kidney says, well, if you don't need phosphate, I give then the sodium-dependent phosphate transporters get downregulated, and then you have reduced phosphate reabsorption, phosphaturia, and hypophosphatemia. In addition, FGF23 downregulates the synthesis of calcitriol by inhibiting this action of 1-alpha hydroxylase in the kidney. This results in low levels of calcitriol, and calcitriol usually enhances the phosphate absorption in the gut. And if the low levels of 125 are there, there's less phosphate absorption from the gut. And this makes sense because both mechanisms result in low levels of phosphate, and low phosphate is a denominator of all kinds of rickets and also of osteomalacia, because without phosphate, there's no proper mineralization of the bone, and the children present with rickets. And of course, also if the bone is not mineralized, then the patients also have osteomalacia. And since adults don't have growth cartilage, they only have osteomalacia. So the symptoms, the frequent symptoms are rickets and osteomalacia. You can see here, typical also genovarus and genovalgus. And the children usually are getting diagnosed at the time when they are supposed to start walking, because they have a wide-based gait and they may have increased width of the limbs, so rickety signs, as we know from other kinds of rickets, and they show a disproportionate short stature. So overall, they show growth failure. But if you look at the children, you see that the trunk then is rather preserved and they have rather short legs. The problem is that physiologically, infants have a varus deformity, and sometimes if there's no skilled pediatrician, they think, oh, it's just a varus deformity and the child has still to growth and it will go away. And however, it's just a sign of leg bowing due to rickets. Since PEX is not only expressed in bone, but also in the teeth, it's in the odontoblasts and also in the dentoplast. This results in odontomalacia. That means the patients have a weak dentine. And if there are small fissures here, like in every one of us, if the dentine is weak, then bacteria can pass through, can go into the pulp chamber, and then you get abscesses. So these patients here don't have caries. It doesn't look bad, but in obviously healthy teeth, somehow there are tooth abscess. And this is typical for this disease. And then there are rare symptoms like craniosynostosis. Children also tend to have a dolgicephalus. They also tend to have a frontal bossing, and they could have Chiari type 1 malformation, like you can see. Patients may present with headache, for example. And then in adults, a huge problem is periodontitis, and this is also related to the fact there's also the dentoplasts are not really functioning, and it's a major problem that adult patients, if they're not adequately treated, can have tooth loss. And then, as it is associated with increasing age in adult, hearing loss, tinnitus, vertigo, spinal stenosis, which could be really, really very tough. There are calcifications of the tendons in the spine. Then pseudofractures, that's the most worst case scenario of osteomalacia, typically in adults, luckily not in children. And then there's a variety of degenerative processes, which are, for example, osteoarthritis and entesopathy, which results in the end to stiffness, impaired mobility. And this is not easy to differentiate with osteomalacia, which is usually responding to the available treatments what we have. And I'm really lucky that I'm a pediatrician and that I don't have to differentiate this. And it's a real challenge. That's what I learned from the physicians taking care for adult patients, to differentiate if a patient have bone pain, skeletal stiffness, what does it come from? And then there's a tendency for obesity and as well as hypertension. So historically, we could not do much, but it was not bad in the end. So we could just add what's lost. Like if you fuel up your motor, you give a lot of phosphate, and then you give a lot of active vitamin D to increase the phosphate absorption in the gut, but also to inhibit this secondary hyperthyroidism, which would occur if you only give phosphate to the patients. By doing that, the phosphate levels are not constantly elevated, but you have some small peaks, and you have an improvement in rickets. But however, as you know, as a rule of thumb, in the end, about half of our patients need orthopedic surgery before adulthood. So the improvement of rickets is not optimal, and there are many adverse events, especially nephrocalcinosis and hyperthyroidism. Since 2018, we have a new drug available. It's an antibody against FGF23 called burosumab. And for children, there's a huge evidence. So we always say later on, we recommend, as there was a randomized controlled trial in children aged between 5 and 12 years old, demonstrating the superiority of rickets healing, improvement in physical functioning, growth, and patient-reported outcome measures in children compared to phosphate and active vitamin D. Robust, very robust evidence in severely affected children is much better. With respect to adults, there was only a trial, randomized trial comparing burosumab with placebo in patients who had pseudofractures or fractures. But here it was clear that the healing of osteomalacia and pseudofractures, and as well as improvement of stiffness, was incredible, which was much more than the extent usually seen with all phosphate and active vitamin D. But there was no comparative trial between phosphate and active vitamin D and burosumab. That makes later on the recommendations more tricky for the adults. That's why we end up often we say we suggest. So in 2019, we were very happy to finish the guideline at this stage, but at this stage, only a minority of the team had experience with the burosumab, because at this stage it was just used in the clinical trials. So 5 years later, we thought it's time to make an update, especially because of the new knowledge of the efficacy of the drug, and of course, as we all have experience in the treatment with this drug. So this was a wonderful team. I really enjoyed it. We have 24 members in the team, and we also have a patient representative, and it's a really great pleasure for me that Marta is also co-moderating today this webinar, because she was part of the patient association team. And these are the lovely people who were all very helpful. We had really all in the team, starting from pediatrics, adult, nephrology, endocrinology, orthopedics, rheumatology. The whole team was, and dentistry, of course, and patient representative. And then very helpful, we had an external panel, which was extremely important because they independently assessed all our recommendations, and they had to say yes or no. And if there was any doubt with the recommendation came back to the team, and we worked on this again until it was solved. So we had 2 independent teams working on the guideline, which was very helpful, because this was reassuring the core team that it was probably good what we did. And then we are extremely delighted and proud that the guideline was endorsed by 13 European society and reference network, and I would especially like to point out the Endo-ERN. Okay, what's new? I would, for time's reason, I would focus today on major topics, but especially on that was changed. With the diagnosis, there were just minor changes, and the major changes was in the treatment part with burosumab, because we now give guidance, much more details on what to do and maybe what not to do. We use the same grading system, and if you just would memorize that, if in the wording there's written we recommend, then it's a strong or moderate recommendation, where usually adequately designed trials must be present. And if there's only less evidence or the benefit and harm are only balanced, then it's a weak recommendation, and then we write suggest. So recommend, suggest. So first of all, this was not changed. The diagnosis of XLH should be suggested in the presence of clinical, biochemical, and radiological signs of rickets, impaired growth, low phosphate, and especially in case of low family history. And you see already here, we always recommend to do genetic testing unless there's a positive family history, and you may not want to do that. But most families usually are very keen that this is definitely assured. So in adults or adolescents with growth plate, they don't have rickets. So you may focus on lower limb deformities, and you look for clinical and radiological signs of osteomalacia, pseudofracture, and patients may even have early signs of osteoarthritis, spinal degeneration, dental abscesses, or endometaphies, and of course, low phosphate levels. And you see here, it's isolated renal phosphate wasting. That's we added this time because it's isolated. So there's no other molecules should be lost in the kidney. The diagnosis for the workup. So of course, we need a clinical workup, checking for rickets, dental abnormalities, sign of granulocytosis, intracranial hypertension, which could lead to the diagnosis of GR malformation, osteomalacia in adults, of course, these things, which are not easy to diagnose. And we recommend a thorough orthopedic assessment, especially in those patients who have some kinds of lower limb deformity. It's always the question, well, we recommend to grade rickets. There's now the possibility to do the rickets severity score, but then you need 2 limbs. And I'm living in Germany, and in Germany we are not very keen on radiological exposure. So some of our colleagues say we do just the wrist in older children, or look at the knees in younger children. That may also do the job. Then biochemically, it's not much to do. Alkaline phosphatase is a surrogate marker of osteomalacia. Phosphate, very important. The new reference values available for the last 10 years are made from children who are non-fasting or fasting, whatever. And so that's why we say it's not mandatory for the check if that is a fasting level. Calcium PDH, vitamin D, 125, intact F223 when available, and of course serum creatinine. And then you have to look in the urine, calcium phosphate and creatinine. Spot urine is fine in children, and it's recommended in 24-hour urine in adults. However, some colleagues who are treating adults are also happy with several spot urines. And then you have to calculate the renal tubular phosphate wasting with DMP over GFR, and urine phosphate creatinine ratio is also very helpful, because if this is very low, but the phosphate creatinine ratio is also low, then it's clear that obviously there's nothing lost in the urine. So patients will have probably a problem in the gut and not a renal phosphate wasting. And then you have to check hypocalciuria. And then, of course, all the stuff what usually the proximal renal tubule does. And if it does not work, there's no bicarbonate, amino acid loss, glucose, and no molecular weight markers. And this is just for the beautiful world where the pediatric nephrologists live. We are very keen on Fanconi syndrome, and there are several diseases causing Fanconi syndrome, and these are the basic message of that. And if there's some kind of this stuff, then you have to check all the forms of Fanconi syndrome. And then why the 125 and why calcium creatinine ratio? Usually 125 is in the lower normal range, and you are in a calcium creatinine ratio as well. Because if FGF23 is high, then 125 is suppressed. So usually the patients tend to have low calcium creatinine. And if this is elevated, then something is wrong in the kidney, and that's usually a defect of the sodium-dependent phosphate transporter, MP2A and 2C, and they cause hyperphosphatemic rickets of hypocalciuria, which can manifest at any age, and then infantile hypocalcemia usually manifests in the first week of life. And it's important to diagnose this because if you would treat those patients with active vitamin D or with brusumab, you will kill the kidney because you get profound hypercalciuria. So if you do this, it's if you should confirm this with PEX gene analysis, and if it's negative, then you should always work first. You look for intron mutations or whatever. You talk with your human geneticist, but you should consider other causes of hyperphosphatemia. And I just showed you in 2 minutes in the new algorithm. So elevated FGFR3, it's not only X-linked hypophosphatemia who cause that. There are many genetic forms, also recessive forms, but then there are also some tricky diseases where patients have hypodysplasia, which could be part of McCune-Albright syndrome, where patients have elevated FGFR3. There could be tumor-induced automalacia, which also have these levels. Usually patients who are diagnosed at later age, they have severe pain, and then also other syndromes like epidermal nervous syndrome. So what about FGF23? If you look at the our previous algorithm, I love this algorithm. It's very didactic and it's true. And I just would like to highlight, so you see if there's high PTH, if it's elevated, then you're in a form of calcipenic rickets. And if it's low, you have to check if there's no loss of phosphate in the urine, the phosphate creatinine ratio. If it's low, then they have a problem in the gut. And if not, we would like to differentiate between FGF23 driven diseases and non-driven diseases. These are the primary tubal losses. And then you will set here, measure levels of FGF23. If you saw FGF23 not intact or see that it's FGF23. And then you look here, we set high, normal or low. And let's see if this is true, because there's no evidence. In a nice study done in North America, they could demonstrate that if you measure intact FGF23, there's a cutoff of 27 picogram per milliliter with a 100% sensitivity and specificity to differentiate between all forms who are FGF23 driven, include tumor-induced automalacia or XLH, and other forms. And as a message, the C term or total FGFR3 doesn't do the job. There's a huge overlap. So if you measure something, go for FGFR3. And then there was the question, what's 27 picogram per ml? We thought, well, that's we have to find out. So we did a reference study with children, and as you can see, the 27 picogram milliliter is exactly the 3rd percentile. That means if a patient presents with hyperphosphatemia and has an FGFR3 level above the 3rd percentile, then it's inadequate. Then there's evidence for FGF23 mediated hyperphosphatemia, and that's why we now state not elevated, we state non-suppressed plasma levels of intact FGFR23 support the diagnosis of XLH, patients with adult hyperphosphatemia, and the cutoff value, that's the hemotopic assay, what we used, is 27, and as rule of thumb, something between the 3rd and 12th percentile, if you have another assay. So let's go to the algorithm. So people were not happy with the algorithm because they always said, Dieter, well, wonderful, super, I understand, but I don't know, have the FGF3 available. Can you do the algorithm without it? And they said, well, we try our best. So we start with a patient presenting with rickets. We want to assure that there's no metabolic acidosis, because this can also cause rickets. Then you look at phosphate levels if they are low. If you're not sure if they are low, you can use the online calculator from the ESPN, where you can also get set scores. And you see the as a dot of your patient in the percentile. And if you later on treat the patient with brusumab, you can see also where the patient lies with a set score or with the percentiles. I usually print it out and show my patients, so they are very happy to see where they are with their parameters. Then you, of course, you have to check high PTH to rule out calcipenic rickets. Then if there's almost no phosphate creatinine ratio or low phosphate creatinine ratio, then you have a problem in the gut. If not, you have to check for all kinds of Fanconi syndrome indicators. And then the next step, you have to look for hypercalciuria, high 125 or suppressed FGF23. You could see it's either of those. If you have something of this, then you should really check the sodium-dependent phosphate transporter, these genes. And if not, you are in the wonderful world I don't know if it's wonderful, but at least for diagnostic purposes, it's very interesting. You have the acquired or the hereditary forms, and the acquired are the tumor-induced osteomalacia. You have to make a thorough workup for the patient, and then you have the genetic forms, and of course a pedigree helps, and you need to confirm with genetic testing. You see, you can go here down to three differential diagnoses within 24 hours. These are all cheap tests. So treatment in children. There was always the question at the beginning, when I have now Buruzumab available and the patient is already on active vitamin D and phosphate, should I switch then, or what should I do? And then we said, well, I think one decision is always, is it satisfactory? Is it good? So we have to define what would be good in a patient when he started or she started on phosphate and active vitamin D, and that's the definition for children. So within 12 months, a significant improvement in rickets, including bone pain, alkaline phosphatase, and within 24 months, significant improvement of leg deformities and normal growth velocity. And of course, you all know that not everyone may achieve a satisfactory response. But if this would be like that, then it would be fine. With Buruzumab, it's a total game changer. There's a rapid improvement in renal phosphate wasting within a few months, better pain within 6 months, improvement of alkaline phosphatase, 12 months, normalization in the majority of alkaline phosphatase after 12 months, improvement, radial signs of rickets, and then catch-up growth, at least a little bit, or stabilization of growth, and the improvement of bone deformity happen, but usually they get evident in the second year of treatment. So that's, we say, well, let's define when we are happy, because when you have later on a patient on Buruzumab and you're considering, is this the response I can expect, or do I have to change something? You have to define what is the satisfactory response. So we said within 6 months, significant improvement of renal phosphate wasting, serum phosphate, rickets activity, including bone pain and alkaline phosphatase levels, and within 24 months, a progressive improvement of leg deformities, alkaline phosphate levels in the age-related normal range, and the normal growth velocity. And of course, this can be expected in the vast majority of patients. If this does not happen, something is wrong. So based on the randomized trial, there was a high evidence level. It's a B moderate. We recommend that patients in the age range of 1 to 17 years, because it's not licensed in the first year of life yet, should be treated with Buruzumab. And in infants, or if it's not eligible for treatment because of infants, or when Buruzumab is not available, we recommend treating patients with all phosphate active vitamin D. And then there was the question, when should patients be switched if they are already on active vitamin D and phosphate? So we said, if there's no satisfactory response, that's why we defined it, then we recommend to switch. If there's a significant adverse effect, like progressive or severe nephrocalcinosis, gastrointestinal discomfort, diarrhea, hypothyroidism, and hypocalcemia, we recommend. If the patients are not adhere to therapy with oral phosphate active vitamin D, well, there are many, especially adolescents, who just can't do it anymore. And this is also then a reason to change. And then, of course, if there's persistent short stature, because there seems to be a better growth, at least on the long term, we recommend to switch. The starting dose and if the product information is 0.8. However, we know that a starting dose of 0.5 may be sufficient in many children, because a few years ago, this was the official starting dose, and many patients did fine with that. So we said, well, you can also use a little bit lower dose. The dosage should be rounded up to the closest 10 milligram, and just that you don't waste too much of the drug. However, if a small child, I usually don't go to 10 milligram if the dosage would be 6. So I'm a little bit more prudent about that. First injection of supervision, and then it's good to encourage patients, especially and family members, that the injections are done by themselves. So the first target is to raise the serum phosphate levels to the normal range. And there's a clear pharmacokinetic effect. So at 7 days, there's the peak of serum phosphate. And at 14 days, just for the next injection, there's the nadir. And if you, in the first time when you start treatment, you would like to detect hyperphosphatemia. So maybe it's good if you do check it after 7 or 8 days. And in the long-term run, it's rather good to look for detect hypophosphatemia after 14 days to check this. So always consider the interval of blood sampling, because this makes a lot of disturbance and a lot of fear in the patient, because the phosphate is higher and lower. And usually it's just that the timing was different. So always write down the office when the patient showed up. And then, of course, like always, serial clinical assessments. It's not mandatory to do a radiologic assessment. And we said after 12 to 24 months, you should do it if there's insufficient clinical response. So usually I don't do this anymore unless there's not something. It does not make sense to measure F23 because the assay does not work, because the antibody bounds to F23, it circulates in the blood. And if you put the ELISA on it, then you get a sky-high false high number. We do not recommend adapting the burosumab dose systematically. It's not like if you, for example, give growth hormone based on but rather check on clinical response. We come to that. And if patients have insufficient immune response, we suggest to increase at least after 2 injections, because it has a steady state appears only after 4 weeks. And the increments in the product information are 0.4. However, we felt that in small children below 20 kilogram, 0.2 milligram may be appropriate. And as said, you should not increase more frequently than every 4 weeks. This is now a totally changed world with the disease, and we should be very keen that the patients and the family are happy with the treatment. If you call them in for every 2 weeks and check, everyone gets nervous, and there's no need for that. So don't change the medication and the dosage too much. It works usually anyway. Give a little bit time for that. What should we do if patients have insufficient response? We should check calcium and vitamin D deficiency, so vitamin D level. And calcium deficiency can nicely be detected by a low calcium creatinine ratio. And of course, hypothyroidism you can check. And then if the patient inject the drug by themselves, you have to, of course, check for non-adherence, administration of wrong dosages, and inadequate injection modalities. And if the system is running, everyone is happy, then you can see the patients between 3 or 6 months, depending on the clinical setting. So you are not in a clinical trial. You are treating a patient. And in the clinical trial, the aim was to normalize phosphate and then to meet the primary endpoint, which was substantial healing of the rickets severity score. So they had the aim to achieve a normal level, which they defined in the trial, the children 5 to 12 years above 3.2. So that was in the trial. And that was the reason why later on in the product information, it's written normalize phosphate level into the lower normal range. But if you look here, you see that the patients were just a little bit above the lower normal range for the mean. Anyway, 50 of 52 children achieved a so-called normal phosphate level defined by that. But then I always thought 1 millimole per liter normal range. And in the recent reference values established in the last 10 years from Germany, the HUB study, also the wonderful Canadian study, the Caliper study, the most robust study in the world with more than 3,000 children, they show that the normal range is much higher, especially in young children. If you set it here, then it's not normal. And if you got the patient come back to you and the phosphate level is 1.1, then it's not normal. Then you should increase burosumab, or what should you do? What is it all about? We then made an analysis, and which first looked what happened in the clinical trial. I did not look at the absolute levels. We looked at the change. The change in millimole per liter plus was about 0.25 millimole per liter after 40 or 0.3 after 64 weeks. And if you looked in our real-world study in 93 children and adolescents in Germany, we saw a similar increase in absolute values. But when you looked at the set score, I did not show you here in the absolute set score, you see that the mean value, the median value was just at -2 standard deviation. That means that 50% of our patients had mild hyperphosphatemia. We said, well, per definition, to adequate reference value, it's mild hyperphosphatemia. But when you look here, you can see the alkaline phosphatase normalized. So in 80% of the patients, alkaline phosphatase normalized despite persistence of mild hyperphosphatemia. This indicates that it's not mandatory to normalize phosphate level to get a nice healing of osteomalacia and rickets. And the other thing, what you can see here, is that as a rule of thumb, the adolescents need less doses compared to the children to achieve the similar skeletal response. And you can also see there's a huge variability. And please remember that in the clinical trial, patients had to have a ricket severity score above 2 or 0.5, despite continuous treatment for a long time with phosphate active vitamin D. So they were the most severe patients who were randomized in the trial, and then they had a dosage of 0.8 or 1.1. But in the real world, you may also have patients with a milder phenotype. That's may explain why you have this variability. These doctors who are treating these patients are not stupid. They did their very best, and you can see that somehow they adapted it. This was in Germany. In London, they had the same problem, and they made a similar analysis. They just looked in their cohort, those patients with normalized, patients within the lower limit of normal or below. And you can see in these patients, irrespectively of normalization of phosphate or not, they had the same improvement in alkaline phosphatase. So this seems to be robust. That's why we said after 6 or 12 months, we suggest keeping the burosumab dose unchanged in patients showing satisfactory response as defined above, even if serum phosphate levels are a little bit lowerish. Transition, well, I learned from the endocrinologists, they told me, well, Dieter, you know, if growth is over, the peak bone strength is still increasing and the bone mass increases until the mid-20s. It depends on the spine or which bone you look, but usually the bone mass accrual continues. And I also learned that if the bone mass accrual is not optimal, then you have the problem of aging. And if you have a proper bone mass at the age of 30 years, you can survive the aging. But if you have not a proper achievement, then you have a higher risk of fracture. That's why we would recommend that as long as you have bone mass accrual, you only want that to have bone mass accrual, that you want to have a satisfactory mineralization. That's why we said we recommend continue burosumab treatment beyond completion of growth and suggest even keeping up at least to the middle of the 30 decade. That's if available, and it's not, we suggest to give all phosphate active vitamin D. And of course, after the age of 18 years, the recommended dose is 1 milligram per kilogram after 4 weeks. Now we come to the adults, and we did the same thing that we first defined the satisfactory response. You see here it's with phosphate active vitamin D. You see we gave us a much more longer time because it takes time in adults until you see an improvement. We would like to see an improvement in musculoskeletal pain, stiffness, and sign of osteomalacia, including radiological lesions like pseudofracture and normalization of total or bone-specific phosphate if it was elevated at the beginning. Of course, not everyone may achieve a satisfactory response, and with respect to burosumab, much quicker response we would like to see within 6 months. Either phosphate wasting, serum phosphate level get better, musculoskeletal pain within 12 months, improvement, musculoskeletal pain and stiffness, and then the radial signs of osteomalacia and radial lesion should be better within 12 months. And of course, as this treatment is more effective, known from the randomized trial against placebo, it can be expected in most of the patients. So first of all, who should be considered for treatment? So there seems to be some or many, I don't know, asymptomatic adults. So if their patients are asymptomatic, you don't need specific treatment. However, a careful clinical assessment is needed to establish asymptomatic disease, as many adults adapt by minimizing their activities. And I'm a pediatrician. However, when the parents come to me and they show their child probably with XLH and I diagnose this, then as a rule of thumb, many of those have at least an affected parent. And then I ask, are you in treatment? No, I don't need treatment. Are you sick? No, I'm not sick. And then I say, okay, let's wait. Let's start with the first with the child. Then they come next time with, oh, are you? What is your job? What are you doing? Yeah, I have problems walking stairs. Ah, yeah. Go to the next door. Start with treatment. So always do history and ask, because many patients, adult patients, just minimize their daily physical activities to not to have severe symptoms. So, however, if patients have significant symptoms, including pseudofractures, pain, stiffness, biochemical abnormalities, radiological abnormalities, we recommend treating them. That's a B moderate. And we recommend also patients undergoing planned orthopedic surgery or dental surgery. So the question is, how should they be treated? So since there were no clinical trials done with the comparison of burosumab with active vitamin D and phosphate, we were had no evidence to say, well, everyone needs burosumab. So we said, well, maybe if a patient has some minor symptoms, minor skeletal problems, then it's worth to start with active vitamin D and phosphate. And patients should, of course, start it on burosumab if they have pseudofracture or they have insufficient musculoskeletal response on active vitamin D or phosphate. And those patients with adverse effects, intolerance to therapy, which is again the same scenario as in children, nephrocalcinosis, kidney stones, hypothyroidism, gastrointestinal discomfort, and diarrhea. The starting dose is 1 milligram per kilogram every 4 weeks. It should, of course, not given together with phosphate and active vitamin D. And then again, the same timing. So you should check at the beginning rather the phosphate levels after 7 to 11 days to detect hyperphosphatemia, and later on at between injections to detect hypophosphatemia. And if the patient gets usually 1 milligram per kilogram, but if there's insufficient response, you may increase the dose to a maximum of 90 milligram, of course, but check that serum phosphate levels are still below the upper limit of normal. So patients who do not respond on burosumab, you have to check if there's hyperthyroidism, calcium deprivation, low calcium creatine level, low adherence, inadequate injections, and of course, if phosphate is above, you should not do it. And if it's elevated, you can restart it with a half of the dose, which is rarely the case. So special considerations in adults. We recommend contraceptive measures in sexually active fertile women on burosumab. This is not only for burosumab, this is for all antibody who can be given to patients for various diseases, because the antibody could pass through the placenta and go to the circulation of the fetus or embryo and could be harmful. So that's why we recommend to do that. And if the woman plans pregnancy or pregnancy is identified, it's recommended to stop it. And then, of course, if there are a reaction of the reduced kidney function. And then is the question, if a patient gets pregnant, what to do? And we suggest considering, so it is not suggest doing it, but considering with active vitamin D and phosphate, because we feel that I think the woman need more calcium and phosphate for also mineralization of their own skeleton, but also of the embryo. And in the last trimester, we were more keen for that. We said we suggest treating with active vitamin D and phosphate, and then this I just mentioned. And with breastfeeding women, there's one study, they measured the burosumab in the breast milk and there was almost nothing. That's why it's not contraindicated. And of course, I think it's allowed that women who are breastfeeding, especially those who have a severe disease that they are restarted on Burzumab. That seems to be fine. Always the questions in adults, so they don't only have the skeletal disease, they only have ongoing oral manifestations. So the clinical trials were not done for that, but we know that both oral phosphate active vitamin D and Burzumab is very helpful for oral manifestation. And of course, you can use either of both drugs. There seems to be both effective and for reducing the number of dental infections and severity of periodontitis. So in summary, XLH is a complex disease. I just showed you the main symptoms today, and it requires a lifelong multidisciplinary care. In the new update of the guideline, we recommend as first-line treatment with Burzumab, and if available, we suggest continue it at least until the mid-30s. Adults, if there's musculoskeletal symptoms, as a first line, we recommend starting with oral phosphate, and if patients who have pseudofractures, insufficient musculoskeletal response, or significant adverse effect, we recommend to switch to Burzumab or start with Burzumab. And of course, the patients need close monitoring of oral health and proactive treatment. So always ask for the teeth, because if the tooth is gone, then it's gone. Every 6 months, patients should go to the dentist. They should be proactive for periodontitis prophylaxis, because it's a very aggressive manifestation, and always encourage the patient to look for their teeth, because when they are gone, then they are gone. Having said this, I would like to thank you for your attention.
Thank you very much for this amazing presentation. That was wonderful. I think we can perhaps go out of the screen sharing mode, so that we can all see each other now.
Yeah. Can you deactivate it, because I don't know how to deactivate the screen sharing.
Amelia, can you do that?
Now it's gone. Okay, because I didn't know how to do that.
Now it wants me to share something, but I have nothing to share. That was great. To me, it is always very impressive to see how much work there is in the detail. I think with Burzumab, we had a real game changer, especially in the pediatric settings, in the care of these patients. And it was great work that these clinical practice recommendations are there and are available to all of us. There are, even with these recommendations, I think there are so many ultra rare conditions and situations where it's really good that we can connect with experts and have these CPMS meetings to discuss these patients. We had some TO cases in the pediatric setting, which were very challenging indeed. And so this is really good. I think in the chat, there are no questions right now. And I'm not sure if Marta, did we lose you?
No, I'm here.
Ah, there you are. Did you have any questions?
Yeah, maybe I have a question. When you change the patients from the children's doses to the adults' doses, some of the children seem to have problems with this change, and they start to have more pain and reduced energy. And I would like to know, how do you deal with these patients?
Good question. So, Marta, the challenge is that if the patients are, if they stop growing, and I already switch it to 1 milligram per kilogram, and then they have more symptoms, then it's more easy to switch again back to every 2 weeks. But if the patients are adults, then I'm not allowed to give it every 2 weeks. I know that there are some colleagues who are doing this, but they can go to jail, I would say, if you do that. And so so it's tricky. So first of all, I would increase the dose up to 90 milligram to be in the interval, but be sure after 7 or 8 days that phosphate is not too high. So the trick is if you give a higher dose, then you may have a pharmacokinetic profile like this, and then you can increase it, but assure that its phosphate is not getting too high. That's the only thing, and we have to see how this will be in later times, because maybe some of the young adults may benefit from giving it every 3 weeks or something. But this is an off-label use of a very expensive drug, and if the health authorities will detect this, someone get real problems. So it's not easy to solve. I heard this a lot, and yeah, it's not easy.
Yeah, actually, there
you're
are
also
quite...
aware.
Go ahead.
Okay.
There are quite some questions for the transition period. What is it you use to monitor in the transition period for the dosage?
It's so if you start it, then I usually would say after 1 or 3 months I would recheck it, and then if it's running, then keep it. You know, the thing is that usually if you switch to 1 milligram per kilogram, it's not expected that you have too high phosphate. That's usually not the case, because the patient are still young, have a lot of bone activity going, so their hyperphosphatemia is not expected, so nothing can happen really. The only thing which can happen is what Marta just raised up the point, that the patients feel that they may have not enough phosphate around in the body. But this is not a safety reason.
Yeah, I think the question pertained more to what is it that you monitor? Is it phosphate exclusively? Is it because...
No, it's sorry, I didn't get it. So it's the same. It's you have serum phosphate. You look at phosphate, creatinine, and calcium in urine to calculate TMP over GFR and calcium creatinine ratio. It's always good to have, and you look for alkaline phosphatase, and many adult physicians usually go for the bone alkaline phosphatase because they feel that sometimes they have a liver problem and they would like to have it like that. And then you do once yearly vitamin D levels. That's it. And PDH every 3 to 6 months, especially in those who had a tendency for high PDH levels.
Okay, thank you. So now there are more questions coming. Thank you for a brilliant talk. How do you suggest managing hypercalciuria on brusumab treatment?
Good question. So hypercalciuria, this could be also due to severe hypothyroidism. We have to check this. And first of all, if the patients have 25, you should stop it. Patients should have at least 1 or better 2 liter of fluid intake. You may start thiazides to reduce calciuria. And if the patients have really hypothyroidism going on, you have to thoroughly check if you see hypothyroid glands over there, considering parathyroidectomy, or of course you can, that's also in the guidelines, start with cinacalcect. So
there has been a warning, right, for hypercalcemia if there is tertiary hyperparathyroidism that has just gone out.
The problem is if the patient had 15 years of phosphate-active vitamin D treatment and then they get stopped, the parathyroid glands are already mad. And even if you give brusumab, you can't cure it. So I think I hope that this problem will go away in a few years when the patients are younger, the children, and they are more switched early to that. But this is rarely the case, but this may happen. So symptomatically for nephrocalcinosis with thiazides, a lot of drinking, and then stop vitamin D, consider cinacalcet in patients with hyperthyroidism. If it does not work, consider parathyroidectomy.
Yeah,
And
thank you.
with it.
So the next question could actually describe a patient of mine. What do you do with a pediatric patient on buruzumab in whom phosphate levels normalize, but bone pain and ALP elevation persist? Increase buruzumab?
Yeah, this I didn't show today. There was a slide which I did not show, but it was interesting because I was considering this, and then I didn't mention it, and then Francesca Emma came and said, "Well, I think we have to state something for this situation." I said, "Oh, really?" And then I told him, "You may do some wording." So what we end up is that even if the phosphate levels are in the lower normal range, but alkaline phosphatase activity is very high persistently and bone pain is present, you may allow to increase the buruzumab dosage unless buruzumab does not elevate phosphate too much. So careful monitoring over 7 days, so that it's not 0.6 or 0.7 millimole per liter, but you may try to increase a little bit. And the other thing is it may need time. But there's a paragraph in the guideline.
Yeah, it is tricky though. I had a patient where ALP would not normalize, and the mother requested increasing the dose of buruzumab, and then there seemed to have been always a relief of the pain symptomatic, and then it returned, but it had no effect on ALP whatsoever.
But phosphate went up, or?
No. Everything else was fine, but growth was really impaired in that girl as well, and we couldn't figure out what was going on.
So sometimes especially in very active young children, they biochemically unhappy. Phosphate is in lower normal range, alkaline phosphatase goes down, even the X-ray looks good, but the child and the family, they notice that after 10 days, pain is coming if the child is or not. And then there's always a discussion, should I increase a little bit the buruzumab dose? And then sometimes I increase a little bit. And then after 7 days, I check for serum phosphate level, there is 0.6. And there's it's 0.6, that's too high, and then reduce it a little bit. So this is something I just check if it's working, but if it's not working, I'll go back for safety reasons.
Yeah, that's good advice. So I think we are coming to the end of our webinar. There are no more questions in the chat. Marta, Eva, do you have additional questions?
No, my questions were answered.
Yes, just to know, first of all, I would like to thank you for this excellent talk. I would like to ask, is there any eGFR rate below this, the buruzumab? There is a contraindication to be administered. I think 30, but
yeah, 30, it's 30, but even if it's below 60, you should be very careful.
Mm-hmm.
But I think if the patient has a GFR of 45, and then it's probably, you can just use a lower dosage and just start with a tiny dosage and titrate it accordingly.
Yes, and maybe it's probably an indication because the adverse events of the conventional therapy is hypercalciuria and CKD, so probably lower than 60 ml could be an indication.
Absolutely. If I would not recommend giving a patient with mild to moderate CKD for phosphate and active vitamin D, because phosphate kills then the kidney. I would rather, patient is symptomatic, I would rather start with a tiny dose of buruzumab and titrate it to the best knowledge, like a physician do. That's much more elegant, much more secure. I fully agree.
So we are concluding with elegant nephrological advice, which is always nice to have for the endocrinologists among us. Thank you very much, Dieter, for this excellent talk, for this very comprehensive going through this detailed guideline. It was super helpful. Thank you all for listening, and I hope to see you soon in the next webinar, and wish you all a good evening wherever you are. Thank you.
Thank you very much. Bye-bye.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.